Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with Lyme disease? Find out more right now. My guest this evening is Dr. Eva Rottmann, a rheumatologist right here in Montgomery County. Dr. Eva, welcome to Housecall.
Thank you for having me. It's great being here.
So briefly tell our viewers about your professional background.
Sure. So I'm originally from Maryland, grew up in Silver Spring, Montgomery County here. And since then, I've kind of been up and down the East Coast doing schooling. I went to undergrad at Rutgers University in New Jersey, and then did my medical school education down in Florida. And then my medical training all at Geisinger Medical Center in central Pennsylvania. So we certainly had a lot of tick cases at that time. I did internal medicine training there at Geisinger, and then my fellowship, my rheumatology fellowship there as well. And then since then have come back to Maryland to join my current practice, Arthritis and Rheumatism. We have multiple locations kind of in the DMV area, and I'm primarily at Wheaton and Olney, Maryland.
Terrific. So the topic at hand is Lyme disease. Briefly tell our viewers what exactly is Lyme disease.
Sure. So Lyme disease is primarily a tick-borne illness. So what that means is that a tick infected with this bacterium, Borrelia burgdorferi, attaches onto a human and then can cause a whole host of different symptoms, kind of depending on how early or late you might catch it. And it's named after a town in Lyme, Connecticut, where the first few cases, came out in the 70s. And since then, these constellation of symptoms, plus, maybe some appropriate testing, we diagnose as Lyme.
We'll get into the different symptoms in a moment, but you mentioned that it's tick-borne. So because we associate ticks with summertime, is this a seasonal issue?
It is, and there's been more ticks over time in the Northeast and here in Maryland. I think, a lot of it with multiple factors contributing to it. Some of it, climate change. We've had warmer weather, and so ticks have kind of lived through the winter months and survived into summer. Definitely see an increase of it during the summer months and some more tick bites in general. It's endemic in the Northeast. And so, yes, very much a seasonal type of case, geographically based. So some areas where it's a little bit more, even climate through the year, we may see similar cases throughout the year.
Which geographic areas in the USA are known to have high incidence of Lyme disease?
Here, unfortunately. So yeah, a lot clustered in the Northeast, at least for the US. There's Lyme disease associated with ticks in other parts of the world, and Europe especially. I believe the West Coast has a handful of cases sometimes, but for the most part, over 90% of cases are here in the Northeast.
So what are some of the symptoms of Lyme disease?
Really depends on the stages. So sort of that early localized stage of Lyme, you might see a really classic rash called erythema migrans. So that's that target, we call it a bullseye rash because it looks like the target sign. It's got a red ring around it and a little central clearing. If you see that, of course, it's really kind of classic for early Lyme, but unfortunately, a lot of cases, you maybe only get a partial rash, or it really doesn't show up as a clear target type of sign. And usually if we do see that early stage, you might get the rash, you might get a flu-like illness that comes along with it. So that's going to be more muscle aches, joint pain, sort of low-grade fevers and aches. So that's all early localized Lyme. And then It can go on to have more severe manifestations that are multi-organ, neuropsychiatric involvement, carditis, so inflammation of the heart, or, as a rheumatologist, I see muscle and joint pain, so it can have arthritis as well, kind of in those later stages.
Are there any neurologic manifestations of Lyme disease?
There are. I don't see it as much as a rheumatologist, but in those second stages, so in an early disseminated Lyme, so we're talking about weeks to months after you've already been bitten by a tick. A lot of times people may not even recognize that they were bitten by a tick weeks or months ago. But in those stages, if you didn't get treated with antibiotics, or maybe you were treated, but you had a particularly sticky case that kind of continued on, you can get things like meningitis or neuropathies from it.
So how do you diagnose Lyme disease besides the clinical hints that you're describing?
Yeah, so it's a clinical diagnosis accompanied by the tests. I think the tests are really tricky because they really need to be interpreted in the context of what symptoms that you're having. I usually recommend, you start off by seeing your primary care doctor, probably not going to find your rheumatologist as your first line. But along with your primary care doctor, you might be tested for Lyme if you have the symptoms that fit with either an early or maybe a later stage Lyme. So there are blood tests. There's a direct type of test for Lyme, and then there's an indirect one. And the combination of those tests, one sort of reflexes the other to support or refute if your initial test was positive. So yeah, I mean, there's caveats to it. In that early stage when you just got bitten by a tick, your body may not have enough time to mount a response where you have the antibodies for it. So if you just see the rash itself and then you go get checked, there's a strong chance you might test negative. And kind of vice versa, further on in the course, if you get tested and you get tested positive, it could also be false positives. So, sometimes autoimmune diseases can also trigger some Lyme testing to come back positive, but not truly have Lyme. So it makes it difficult all the time. It's not a black or white just from the testing itself. Should really be interpreted in the context of everything that's going on.
So you mentioned an important point as a rheumatologist. Can you sometimes clinically have a difficulty making a distinction between Lyme arthritis and, let's say, rheumatoid arthritis?
Yeah, I mean, it can be tricky. There are so many different types of arthritis. And so I think a lot of times it's just always best to go in with an open mind. So you don't want to attach onto something and say, is this Lyme or not Lyme arthritis? More so, what is causing your pain? And let's make sure we're doing a comprehensive test. So they are going to behave a little differently. So we use that as clues. So Lyme arthritis, for example, really is more large joint, tends to be one joint at a time, maybe a swollen right knee, maybe we'll move on to a swollen, the other knee gets involved, maybe a shoulder, versus rheumatoid has its own pattern. It likes to involve multiple small joints all at one time. It tends to be a lot more intensely painful as opposed to the Lyme arthritis, where at that point you've had the infection going on for some time and it's sort of hidden and migrated to different joints, but it doesn't tend to be as intensely inflammatory as compared to rheumatoid arthritis, for example. So yeah, really basing it off of patterns and then, the tests, of course.
So you mentioned early diagnosis is very helpful, and we'll get to treatment later during the show. But if somebody has symptoms and they're kind of waxing and waning, what are the consequences of untreated chronic Lyme?
So if you do get bitten by a tick and maybe it gets missed, it's on a location of your body that you didn't see, the back of your neck or the knee, not treating it during the early stages does increase the risk for complications later on. But I won't say that every case of untreated Lyme goes on to have that. Sometimes our immune system will simply fight and clear it off, even without antibiotics. But, generally, if caught early, of course, the recommendation is to treat the infection. If left untreated during those early stages, so that early localized disease, you could go on to get secondary, so stage 2 or stage 3 Lyme, where I had mentioned maybe more neurologic involvement. It can have cardiac involvement, causing things like conduction heart blocks, causing inflammation of the lining of the heart, like carditis. It can cause meningitis. It can cause arthritis and some of the symptoms that I see. So it can be pretty serious if left untreated, but I would say for the most part, that's not the default of what happens. I don't, most patients that do get it, even if not treated, it can resolve on its own.
Okay. And can you get Lyme disease without being bitten by a tick, or is that an absolute requirement?
It is the straightforward answer is no, you do need to be bitten by a tick in order to get Lyme. There's rare cases where it's, passed on maybe through blood transfusion or maternal fetal transmission, but really those are really select scenarios. And for the most part, yes, you need to be bitten by a tick in order to have gotten Lyme. It wouldn't be something where, your cousin coughed on you and then you have Lyme, or you got it because your dog got Lyme and your dog licked you. It could be that the same tick that bit your dog also bit you, or you live in an area that's endemic and a lot of ticks can carry this infection. And so you're in the same household. It's not uncommon for multiple people to get it at the same time because they were all bitten by a tick. So if you do test for Lyme positive and you have all the signs and symptoms and it fits with Lyme, at some point you were bitten by a tick.
And just to underline what you made earlier, the comment, Lyme disease is not contagious. It's not communicated from one person to another.
Right. It's not the way we think about, let's say, COVID, for example, or another viral infection where you might pass on through your secretions or, a sexually transmitted disease. So no, it's not contagious in that way.
Among the rheumatologists, given the clinical presentations, including arthritis, is this viewed as some sort of autoimmune disease, or is it apart from that? Is there any autoimmune dysfunction that occurs as a result of Lyme?
Yeah, so kind of yes and no. It's along a spectrum. So in those initial early kind of localized disease, it wouldn't be considered an immune system condition per se. It's primarily an infection and primarily treated with antibiotics to get rid of the infection. Even in the later stages where it's early disseminated disease, while there is an immune system response to it, for the most part, it's not so much an autoimmune response where our body's immune system cells are attacking its own self tissue. It's very much still fighting off, an invading bacteria. And so the treatment is still going to be antibiotics. But there are cases that are refractory to antibiotics, even beyond use of things like IV antibiotics. You can develop this intensely inflammatory type of response to it. And then with Lyme arthritis, we do see cases where it develops more of an autoimmune type of arthritis, where excessive immune cells are triggered and it creates this inflammatory response where some patients need to be on immune suppressant medications. They're definitely in the minority. It's primarily an infection first and foremost, but later stages can develop an autoimmune component to it.
We're going to pause briefly for a public service announcement. More with our guest, Dr. Eva Rottmann, and we're discussing Lyme disease. We'll be right back.
I don't think that many kids in my son's school even do it.
He makes fun of his friend who vapes.
He would never try it.
She's into soccer.
She's on the honor roll.
She's just not the type.
No way.
No way.
No way.
No way, my kid would never vape.
Get your head out of the cloud. Today, nearly 8,000 kids will start vaping, maybe even yours. Learn about the dangers at talkaboutvaping.org.
We're back. My guest this evening is Dr. Eva Rottmann, and we're discussing Lyme disease. Eva, when we paused for the break, we were discussing the many challenges of Lyme disease. One thing you had mentioned was that Lyme disease in other countries and continents such as Europe is actually appearing. Is that the same disease as it is in the USA in terms of the same tick and the same bacterial infection?
So yeah, my understanding of it is that it's a very similar presentation with Lyme disease, but it's not necessarily the same tick hosting the same bacterium, but manifests as the same kind of symptoms as Lyme disease.
Okay, so let's go on to discuss the treatment options for Lyme disease. Let's first focus on early onset Lyme disease. Somebody has erythema chronica migrans, the classic skin manifestation. They may have some flu-like symptoms, maybe a little arthritis. What do you recommend for therapy?
Yeah, so in those early stages, the mainstay of treatment again is going to be antibiotics. It's not something that can clearly go away without using antibiotics, but in the small minority, the symptoms can kind of resolve on their own. So usually doxycycline for about 10 days is the recommended treatment. There's going to be different patient factors. So for example, if you're intolerant to doxycycline or, pregnancy or other reasons you can't take that antibiotic in particular, there's other antibiotic regimens, but yes, for the most part, it's going to be a shorter duration of antibiotics. And then beyond that, there are longer durations of antibiotics, and it just really depends on how severe and what stage of Lyme we're talking about.
So if somebody is treated early in the course of the illness, and they a few weeks later relapse, what do you do then?
Yeah, so in cases of relapse, you may repeat that course. Some people might the course and extend for a little bit of longer duration, but for the most part, simply just repeating another round of antibiotics usually will clear the initial infection.
So a longer course, how long would that be?
It depends. So still in the early stages, we're talking about that 10 to 14 day duration, not something that's months, for example. Really, it's not until we start thinking about stage 2 or stage 3 where longer duration of antibiotics, like a month of antibiotics, come into play. And then, even for those more severe manifestations, sometimes it's IV antibiotics.
And which antibiotic do you give IV?
I believe it's ceftriaxone, but to be honest, some of it starts to get a little bit fuzzy as a rheumatologist, because primarily if they're in the hospital and they're needing IV antibiotics for, let's say, meningitis from their Lyme, it's probably going to be a combination of management between a neurologist and an infectious disease doctor. So typically as a rheumatologist, we don't get too involved until, they have more musculoskeletal type of issues, arthritis, for example.
Now, you mentioned earlier before the break that if somebody has persistent arthritic symptoms, despite the antibiotics, you may actually consider immune suppressive therapy. Are you at all concerned giving immune suppressive therapy to somebody who still may be harboring an infectious agent?
It does get tricky. I think, during those stages, you want to make sure that you're working with an infectious disease doctor as well. Certainly before starting an immune suppressant medication, they've probably already gone through a 30-day treatment cycle for Lyme arthritis, which is still the initial treatment, for arthritis because of the concern for ongoing infection. So if you've completed the course of antibiotics and they still have this inflammatory type of arthritis going on, there's options to repeat that course, maybe use IV antibiotics. So I mentioned the example of a knee involvement. So a lot of times when the knee is swollen with fluid, we're able to take that fluid out using potentially ultrasound guided kind of procedure called an aspiration. So we'll draw the fluid out, draw the fluid out and see if it's still a very inflammatory type of effusion, if there's presence of Lyme in the fluid. So we actually can test PCR in the fluid as well. So sometimes that can be used as a gauge as to whether or not there is still an active infection. Plus testing their direct and indirect testing too. It's not a perfect scenario. Again, it's not black or white, but we can see, decrease in antibody count, for example. And, a combination of that and your clinical judgment, you might decide you don't think there's active infection, but there is still this very persistent inflammatory type of response. And we would start out by using, more anti-inflammatories like even like naproxen. So, we're not necessarily talking about strong immune system medicines. But then beyond that, yes, sometimes there are more disease modifying type of medications that we use.
I should explain to our viewers when you use the abbreviation PCR, that stands for polymerase chain reaction. You mentioned the knee effusions. If you tap the fluid, are you able to actually stain it for the specific infectious agent?
Yeah, so we run that test, that PCR test, to see if there's Lyme. Statistically, it's not highly successful, even if you do have active Lyme. I think it's somewhere along the lines of like 20% or so of people that have Lyme actually have a positive presence of it, from a testable standpoint. But still, when we do find it, it's very helpful and, pretty specific for what's going on. But yes, so we use that to send off, and then also to rule out other conditions too. So, a knee effusion can be explained by a lot of other diseases. Like you mentioned before, rheumatoid arthritis can do that. We see patients with crystal arthritis, so gout can cause the knee to swell up, or even just regular osteoarthritis, more natural degenerative types of changes can also cause a knee effusion as well. So I think in doing that, you're also looking for other conditions that could be contributing to it.
Let's go on to discuss long-term Lyme disease. Somebody, despite recurring courses of doxycycline, is still sick. What do you do in that setting in terms of antibiotics or other therapies?
Yeah, it depends on what symptoms they're having at that point. There is this entity of chronic Lyme, and chronic Lyme in general, I like to think of as two different types. So there's chronic Lyme where it's that inflammatory type of reaction I mentioned earlier, where we start entertaining the idea of anti-inflammatories or maybe immune suppressant medications. And there's clearly an arthritis involved. But then there's Lyme where it's post-treatment Lyme syndrome. And this is a little bit different. The thought is that there's no active infection at this point. There's not an active inflammatory type of issue, but it does cause a whole host of different symptoms. So it can cause fatigue, brain fog, a lot of cognitive difficulties, widespread muscle and joint pain. So, as a rheumatologist, I do see cases where patients may have been treated for Lyme, have gotten multiple rounds of doxycycline, and the thought is that there's no active infection at this point, and I don't see active inflammation, but having been infected in the past with Lyme, even when treated, the thought is that a minority of patients can then develop this syndrome from a number of factors that we can't always explain. It doesn't seem to be an immune system type of response, but it does seem like the infection itself kind of changes the way we process our sensory input, and our pain signaling has changed because of the initial infection. And so we don't have great treatments, the way we think about maybe a course of antibiotics or an immune system medicine. It's really about recognizing it and making sure you rule out other conditions, and then focusing on the individual symptoms for a patient. So it can be really tricky for sure. And I think for patients experiencing it, it's a big impact on their day-to-day well-being and function.
Do you get a sense that there are patients out there who may have had a autoimmune predisposition and that they develop Lyme disease and then it long-term unmasks their autoimmune predisposition, that it triggers a long-term event?
Yeah, I think there's certainly some research that supports that. It's not a completely fleshed out, well-known, understanding, but it's usually a combination of things. So we do know that even within the bacterium itself, certain strains are more immunogenic, that they're more inclined to cause that severe, exaggerated response as opposed to just, a simple bite that causes the bullseye rash. So I think it's a combination. I think there are some patient factors that predispose them to getting a more severe form. And then if you're also infected with the more severe strain, plus maybe some other environmental triggers that we're not all aware of, it's kind of like the perfect storm. All those things come together and you get maybe a more severe case that causes Lyme arthritis, or maybe that post-treatment Lyme syndrome.
Dr. Rottmann, thank you for an excellent interview. If our viewers have any questions about Lyme disease, how can they reach you?
Yeah, so, I'm with a big group out here in the DC, Maryland, Virginia area. Our practice is called Arthritis and Rheumatism Associates. You can visit our website at arapc.com, and we look forward to seeing you. Great.
Well, thank you for an excellent interview. My thanks to my terrific team at the studio, especially my producer, Melissa Amold. And thank you to the viewer for joining us this evening. If you have any questions, you can reach me at my practice website listed at the bottom of the screen. As for my next show, it's going to be an important one. Dr. Evan Siegel, a noted rheumatologist here in Montgomery County, will be reviewing the latest information about osteoporosis. See you then next time on another edition of Housecall. Good evening.